appendage function, a trans-esophageal echocardiographic study by Dr. ganeshAPCSI from SWIMS.
Good afternoon, respected judges, professors, seniors, colleagues and my juniors. I am going to present briefly about our paper, Effect of Percutaneous Mitral Balloon Valvuloplasty on Left Atrial Appendage Function, Trans-Esophageal Echo Study from SWIMS Tirupati. Rheumatic mitral stenosis is still a frequent cause of valve disease, causing major morbidity and mortality in our country. In the past, left atrial appendage has been considered to be a relatively useless part of cardiac anatomy, but is now recognized as a structure with important pathological implications. In fact, left atrial appendage has more compliance and contractility than left atrium. Due to its high compliance and contractility, left atrial appendage prevents stasis of blood. Chronic pressure and volume overload imposed by the mitral stenosis leading to the LA and LAA dysfunction, and it will cause stasis of blood, reduced LA and LAA ejection fraction and atrial fibrillation, thereby producing left atrium and left atrial appendage thrombi and leading to thromboembolic episodes. So assessment of left atrial appendage function is helpful in predicting the risk of thromboembolism. Since by introduction by Inoue et al. In 1984, PBMV has become established as a safe and effective treatment for rheumatic mitral stenosis with results equivalent to the surgical valvotomy. So transesophageal echo is a semi-invasive, highly accurate imaging method to accurately assess the functional efficiency of LAA by Doppler and Doppler tissue imaging. Very few studies in the literature have evaluated the impact of PBMV on LAA function so far. So we did our study to compare left atrial appendage function by Doppler and Doppler tissue imaging before and after PBMV by transesophageal echo. So we included 88 patients with symptomatic severe mitral stenosis with mitral valve area less than 1 centimeter square who underwent percutaneous balloon mitral valvotomy in cardiology department of SWIMS Tirupati between August 2010 to January 2012. Were enrolled those who were fulfilling the PBMV intervention criteria and those who had a successful intervention only were included. Successful PBMV was defined as patients with mitral valve area greater than 1.5 centimeter square with less than moderate MR. So patients with atrial fibrillation, left atrial appendage, left atrium thrombus, MR greater than 2/4, high Wilkins echo score greater than 8, patients who failed to give the consent for TEE after procedure, critically ill patients with NIHA 4, patients pregnancy and patients who had LV systolic dysfunction were excluded. All participants underwent TTE and TEE with Philips IE33 mission before the procedure and again on the third day after PBMV. Routine parameters, LA, LV dimensions, LV ejection fraction and mean gradient and peak pressure gradients across the mitral valve, pulmonary artery systolic pressure were measured in the left lateral decubitus position with routine views. According to the ASC guide, LAA was clearly imaged in TEE from the mid-esophagus in basal short axis view at the aortic valve level around 30 to 60 degrees. And SEC grading, LAA presence of thrombi, LAA area, Doppler and Doppler tissue imaging velocity profile were imaged in this view only. A mean of 3 consecutive cycles was used to calculate all echocardiography parameters. Left atrial appendage maximal and minimal areas were traced by a line drawing from the top of the limbus of the left upper pulmonary vein along the entire endocardial border in end systole and end diastole, correlating with the ECG. And LAA appendage area change percentage was calculated by the formula maximal LAA area minus minimal LAA area divided by maximal LAA area into 100. And LAA Doppler flow profile was obtained by keeping the pulsed Doppler sample volume in the LAA appendage cavity 1 centimeters below the outlet from the mid wall of the LAA without any wall artifacts. The positive wave after the P wave was depicted as LAA late emptying velocity and negative wave after that is displayed as LAA late filling velocity. And Doppler tissue velocities were obtained by keeping the spectral pulsed Doppler volume on the LAA lateral wall midway between the tip and outlet. The triphasic pattern is produced. In this, the A wave is due to the atrial contraction. And after isovolumetric contraction, the LAA moves towards the apex, producing the negative wave, that is S wave. And after the isovolumetric relaxation, the LAA again moves towards the base of the LV, producing the positive wave, the E wave. So triphasic pattern normally produced. This is the representative illustration of one of our study patients, LAA Doppler tissue imaging profile, which was very much, all velocities were, which was significantly increased after the procedure. The statistical analysis was done with SPSS software. Non-parametric continuous variables were tested with paired sample t-test. A p-value less than 0.05 was considered to indicate statistical significance. So among total 88 patients who underwent PBMV, 18 patients with atrial fibrillation, 8 patients who failed to give consent, and 3 patients who had mitral regurgitation greater than or equivalent to the 3 plus MR were excluded. So finally 59 patients were included in our study. So regarding baseline characteristics, mean age of the patients was 33.6 plus or minus 10.3 years. 29 patients were male patients. 71% of patients were female patients. 44% were in NIHA class 2 and 56 patients were in NIHA class 3. Left atrial dimension, LV ejection fraction, LV diastolic and systolic dimensions were not changed much significantly after the procedure. Gradient, maximum and mean gradients across the mitral wall and pulmonary artery systolic pressure was decreased very much significantly after the procedure, and mitral valve area was increased very much significantly after the percutaneous balloon mitral valvuloplasty. Spontaneous echo contrast, that SEC was present in LA and LAA in 10 of the 59 patients before the procedure. SEC was completely disappeared in 6 patients who had grade 1 plus SEC before the procedure and decreased in 4 patients to grade 1 plus who had grade 2 plus before the procedure. In this table, we compared the baseline velocities, baseline Doppler and Doppler tissue imaging velocities in patients with SEC and without SEC. In patients with SEC, LAA emptying and filling velocities were very much statistically significantly low in patients, and Doppler tissue imaging velocities are also low but not statistically significant when compared with patients without SEC, implying more depressed LAA function in patients with SEC. In this table, we compared the LAA function before and after PBMV by TEE. Left atrial appendage late emptying velocity, filling velocity, and all EAS velocities of LAA was increased very much significantly after the procedure, but left atrial appendage area change percentage was not changed significantly. The same data is shown here as bar diagram. So, PBMV by decreasing the LAA afterload acutely reverses the chronic changes in LAA function, and it will increase the LAA blood flow velocities. In our study, 10 patients had SEC, and in another study, Kasliwal et al. From India found that SEC in the LAA was seen in 57.3% of patients on multiplane TEE. We observed no significant change in the left atrial appendage area change percentage, similar to the Osman et al. From Turkey and Rajesh et al. From Chandigarh studies. LAA pulsed Doppler emptying and filling velocities of greater than 60 cm per second in normal healthy controls were found in the Tanageshoglu et al. Study. The LAA Doppler velocities were significantly depressed in mitral stenosis patients. In our study also, baseline LAA Doppler velocities were significantly depressed. So in this table, comparison of LAA Doppler velocities with other studies are shown. Similar to the other studies, in our study also, mitral valve area increased very much significantly, and late emptying and filling velocities are increased very much significantly. But in Osman et al. Study, late filling velocity was not changed very much significantly. And Tanageshoglu et al. Demonstrated 8 wave of greater than 33 plus or minus 4.1 centimeters per second in normotensive healthy controls. In our study, LAA baseline DTA velocities were significantly low when compared with healthy controls. After PBMV, both systolic and diastolic LAA DT velocities were significantly increased in our studies, similar to the Rajesh et al. And et al. Studies. So in this table, we compared the LAA DTI velocity profile with other studies. So finally, successful PBMV will increase the DTI velocities and increases the LAA Doppler velocities and will improve the global and regional LA and LAA function, so that leads to improved clinical status and decreases the intensity of the left atrial appendage. So relief of mitral stenosis by PBMV may not only confer hemodynamic benefits for symptomatic improvement, but also may have a favorable influence on future thromboembolism risk by improving LA and LA. Absence of clinical follow-up is the main limitation of this study. We excluded patients with atrial fibrillation, those with high echo Wilkins score, and those with MR grade greater than 2. So there is a possibility of selection bias. Instead of LAA area, LAA and LAA volumes are not measured. Thank you.
Can we include some of us are not the rest of the book items? Can we include that from Okay, we'll have one question, one complete. One. No, because we're coming close to Sir, you have the last killing. The last paper. Yeah.
Very interesting data you have come out with. The sampling volume, the location of the sample volume, what you have presented. Sample volume you are not presented. The site of sample volume, what you have said between entry point to the area, appendage and relations. But normally what is recommended is the tip of the left atrium. But how you saying that sample volume is kept at the midpoint of the
Middle third, sir, in auto textbook.
what is accepted is the tip of the.
But artifacts will be more when we record from tip, so that it get given.
It has the sample volume mass as known as this. And for the emptying velocity, you need to place the sample volume about say something like 5 millimeters or so away from the entry to the left atrium. So that's something which I found yes. Now, as you yourself have said that the long-term implications of your data is not clear because you have no
Follow-ups.
So the under limitation. Did you assess the approach tolerance by using
No, sir. Just by history.
And then also the venous velocity.
No, sir. Just we measured LA function.
That is one part. From the venous velocity is also. Third is the question that is you classified that into grade 1, 2, 3, 4. My question is how do you classify?
Sir, that is from article Sailari Sadanandan et al. Study is there, sir. In that published study is there, sir. In that they classified like that. So we took the data from that study, articles.
What is it? What do you do? Because the objection will be.
Yes, grade 0, no sex, sir.
I can change the sex from grade 0 to grade 4. If I just start from the gauge. So if you are comparing pre-PBMV and post-PBMV, you must have noted the gauge